My name is Eydie Miller-Ellis, and I am a professor of clinical ophthalmology and director of glaucoma at the Shea Eye Institute at the University of Pennsylvania Perelman School of Medicine.
And I'm Mildred Olivier, and I am professor of surgery in ophthalmology at the Rosalind Franklin University of Medicine and Science, Chicago Medical School. And I do glaucoma at Cook County Hospital as well.
And we attend a lot of meetings together, do a lot of projects together. Yeah, I think it takes, at least a dozen cases to get comfortable enough with any procedure, because there's so much variation in anatomy that you figure out who's easy anatomy, who's not so easy. So if you end up as someone first learning a procedure and you have difficult anatomy for the first few cases, it could turn you off to doing it. If you have some where you had patients with pretty easy anatomy for the first few, then you'd be more enthusiastic about it. Anytime a surgeon is learning a new procedure, it's still new. There's issues with learning it. There's knowing what to do postoperatively. There's a wide variation in anatomy and the way the iris responds in different people. So of course the easiest is a very wide open angle where the trabecular meshwork is very visible and not obscured by the iris at all. Since the patients typically have not, even if you're doing combined cataract and glaucoma surgery, the lens of the eye is still there. So if the patient is a little bit narrow, they're still a little bit narrow when you're doing their trabectome. And so because there's a smaller location to work in, even though you have the irrigation that helps open up the angle, there can be some challenges really having good visibility in some patients to get a good trabectome incision. And I think that's where, doing this for so many years comes in. When I first started doing trabectome, I still find those patients challenging, but it was really challenging early on with patients who had open but slightly sort of narrowish angles to really get good visibility during the surgery.
People really have to know their gonio and know the angle, even when you're going in, and know what the landmarks are, so that, because what I do like about it is that it is a fairly simple procedure. It doesn't take a lot of time, but even I find that before I start, I really have to have the position of the patient's head in the proper way, and the microscope, and really being able to look into the angle to make sure where I am, to make sure that chamber is deeper, and so all those things. I take probably a lot of time just preparing before I do the actual procedure. That's important to make the procedure as easy as it can be.
And you can really see it, like when I teach my residents to do it and they're not as comfortable with the anatomy, it can be very challenging to really teach them how to do it, even though it looks simple. There's a lot of, head adjustments, hand adjustments, and so forth, which is, as opposed to teaching Dr. Olivier, who is very familiar with the anatomy, and it was like a piece of cake teaching her.
Oh, I was still going, where do I put my hand? For me, it was really good when Dr. Miller came in, was on site at my, ASC, and so you could do cases with her. She could tell you things about that would make the cases easier. So there you have a comfort zone, you become more comfortable, I should say, doing the procedure, and then you're more apt to do more and more as time goes on, and patients who actually qualify to get it done, then you'll end up doing it on them and having good results.